Okay, can I go ahead? Are we all set? Yes. Yeah, just want to make sure we're all set. Okay, well, thank you very much, first of all, to Professor El Gandour, that as usual, he put a very nice production, as he always does. So it's a very nice meeting in a beautiful city. And see, my wife, she's from Cairo, so I always love to come to Cairo. It's really beautiful. And I will be talking about a simple approach to the craniovertebral junctions. And we have moved a long way, and I listened to Professor Gragnaniello before talking about approaches that we used to do, the transoral, the transpalatal, and now the extended endoscopic approach, and that was fine because we were very aggressive 10 years ago. We described, amongst other, very complex approaches in which we were able really to expose completely the clivus, the craniovertebral junction. We mobilized the vertebral artery. But the question is that, with experience and with time, maybe we just need to be faster in doing our own surgeries. Probably we realize that many of these approaches, they are not really always necessary. And we contend that the majority of craniovertebral junction tumors, no matter if they are neoplasm, non-neoplasm, or any pathology at the craniovertebral junction, may be addressed by using simple neurosurgical approaches, but provided that you use microneurosurgical fundamentals. Now, what are the microsurgical fundamentals that are important in approaching craniovertebral junction tumors and in general skull-based tumors? The first thing is that you need to respect the arachnoidal plane, because these tumors are usually, they have benign tumor, they always have an arachnoidal plane that separates them from the subarachnoid space where the vessel and the nerves, they are situated. So if you respect the arachnoidal plane, just like you do when you do a vestibular schwannoma, then you are in good shape. The second thing, you need to limit the coagulation. Why? Because when you coagulate, you coalesce, you make a unity between the arachnoidal plane and the tumor, so that makes very challenging and very traumatic further dissection. The third thing, that's a general tenet of skull-based surgery, you must approach the tumors from different angles and have a clear surgical plane. It's always very important. But as in any battle, there is no plane that survives the heat of battle. So you must be able to change your plane. You must not be stubborn. You must be flexible, able to change your plane, and you must be aware of other modality, like, for example, fractionated stereotactic radiosurgery that is very helpful in dealing with this tumor. So this one here is a schwannoma. It's a very large tumor. Patient is operating in the semi-sitting position. We are removing here the posterior arch of C2. And the very important thing is that when you expose this tumor, you must remove the horizontal portion of the occipital squamous. See, the occipital squamous has two portions, a vertical one and an horizontal one. If you don't remove completely the horizontal portion, then you have a lot of bone that prevents you from seeing the tumor and from approaching it. So this one is a schwannoma, so we expose the tumor, we decrease the bulk of the tumor by using the CUSA and other microneurosurgical technique, and working from different angles and working very patiently, then eventually we are able to completely remove this tumor. And as everybody has done skull-based surgery knows, the bigger the tumor, the easier it is to remove the tumor, because the tumor has already created space in the subarachnoid space by its own growth. So really, it's easier to remove a larger tumor than to remove a smaller tumor. And you can see here the removal here. This one here is interesting, is a recurrent arachnoidal synovial cyst. Clearly, all these patients, they were all heavily symptomatic. This one here, the dissection is not as crisp as we would like because it's already been operated before from the back. So we were able to, to just, look how lateral we are just by doing a posterior approach with the patient in the semi-sitting position and following those tenets that I briefly described before. So you can really be very lateral. And again, the horizontal portion of the occipital squamous, and that may seem very simple. But if you don't remove the horizontal portion of the occipital squamous, then you cannot go as lateral as we are able to go in all these cases that we are showing here. So that's very important. Occasionally we use the endoscope just to confirm what our understanding of the three-dimensional situation is. And this one here is a very large meningioma. And I think here you probably see a very nice exposure of this area with the arachnoid intact. Again, the horizontal portion of the occipital squamous has been removed, and see how much lateral we are. And this is a very simple approach, either with a midline incision or with a paramedian incision. That's it. It's just a very, very simple approach. Look how lateral you are. You are you are just in front of the cervico-bulbar junction. And, and then you just follow the same tenet that we said before. You separate the arachnoid from the tumor, and then you start working on the tumor. First from one angle, this one here were almost horizontal. Then during the surgery, we changed the inclination of the microscope, so we are able to go to look upward by changing the angle of the microscope vis-a-vis the patient that is positioned in the semi-sitting position. And again, just by being very patient, by debulking the tumor, you change any tumor, from a huge tumor to a large tumor, then to a small tumor. So, and as I said before, the bigger is the tumor, in a way it's easier, the procedure, because the tumor has already created space that if you are patient and you follow those tenets, you can use very well. And so, you can see at the end, that's again this one. This one here, it's a very interesting case. This one is a patient that was myelopathic and had this small meningioma really coming from almost the lower clivus. And we had many discussions because I operated on this patient a few years ago when all these endoscopic approaches were really extremely popular. But I felt, just based on my previous experience, that we could approach this tumor from the back. And remember, when you do an endoscopic approach to the craniovertebral junction, as very well Christian demonstrated before, there is a lot of access morbidity, because you need to go through the nose, you need to drill the clivus, and all these patients, they have a lot of issues after surgery. I've never heard anybody screaming as much as when these patients that have endoscopic surgery, they come back to have the crust removed, But anyway, so this one here, we have exposed the very lateral, the cervicomedullary junction, and then we have selected a window to approach this tumor by using neuronavigation. And then we use the endoscope to just confirm that was the appropriate window. And then once that we have confirmed that, then we start to work on this very small window that is less than 1 centimeter up and down. And again, we do the same thing. We just expose this tumor we debulk it, using the CUSA or using other microneurosurgical technique. We use the microscope in a navigation mode. I should say we use the microscope in an augmented reality mode, to use a term that is very popular today, because we are able to see the navigation image in the ocular of the microscope, superimposed on the actual image that we see through the microscope. So just by being very patient, see there is no trauma to the brain, we're only working on the tumor, then we are able to debulk this tumor. You must always be very patient, and you must always don't fall prey of the temptation, to remove the tumor in big pieces, because that's usually is where you get in trouble. So although it may seem easier, but is fraught with a lot of potential complications. So instead, you must be patient and working little by little by removing the tumor. And you can see here that we coagulate the dura at the end. And this is the surgical field once we are done. And you can see that we have a very, very good exposure. There is really no trauma to the brain, and we have been able to go all the way in front to the mid-clivus just by using a very simple approach posteriorly, very simple, very quick. And you can see here, this is the window is probably about half a centimeter by half a centimeter. And then at the end, we just use the endoscope just to confirm, although we already know that we had removed the tumor completely. And of course, the approach is very well tolerated. It's very simple. The patient stays in the hospital for a short time, and that's the pre and post-op images. So I'm not going to show any more cases in the interest of time. But, we had some cases of pannus that were removed using this very simple approach. And what we want to stress is that if you use appropriately the fundamentals of microneurosurgery, then you are able to remove this tumor using very simple approach that inflict very little trauma to the patient. So you must respect the arachnoidal plane, you must limit the coagulation, and in that we are used by the sitting position because, of course, for the blood flows away from your surgical field just by gravity. We approach the tumor from different angles, as I have demonstrated. You must have a clear surgical plane, be able to change your plane, and be aware of other modalities to control the tumor. See, radiosurgery is not only gamma knife. Radiosurgery is, especially skull-based surgery, is fractionated stereotactic radiosurgery. So, in conclusion, if microneurosurgical fundamentals are properly mastered and then used, the majority of craniovertebral junction tumors may be safely operated using minimalistic surgical approaches. Thank you.